And what we have seen in the last years and decades, that the number of people living with diabetes is rising, specifically in countries where the number of diabetes cases were low. So in Europe, it's not increasing that much compared to other countries in the world, but still it is becoming a big issue in the coming years. And if you look into the numbers of people where we even do not know that they have diabetes, you can see that also in some westernized countries where you would assume that access to care is quite good, we have half of the people not knowing how or if they have diabetes. Especially my tiny little country here, where we always claim we have good health care in Austria, we have roughly 50% of undiagnosed diabetes cases in adults. And that's, of course, a big problem because uncontrolled diabetes can cause harm. And so the recent standards of care in diabetes by the American Diabetes Association were just published. And they include a risk calculator to see if people are at risk. And I think that's something that we can easily recommend to our patients, and they can then spread the word amongst their peers to really take that risk assessment to see if they are at risk of having diabetes. Because what we also see that half of the ones who have diabetes do not achieve their treatment goals, even if we now have very potent medications, as we have heard of. And also people with diabetes are in many cases affected by obesity or overweight. And cardiorenal metabolic disease is, of course, driven by obesity, hyperinsulinism, and diabetes. And if we do not take care upfront, we see the end organ damage. So from the diabetologist's perspective, we should be the early ones who can start and initiate treatment to really avoid then adverse outcome. There is still a high number of inertia in diabetes. So what we see that only less than half the people have had a recent treatment intensification, even if they have HbA1c levels above the target. And the people who have HbA1c in the range of 7 to 7.9 are the ones that we definitely need to target, because they have the highest probability at least to achieve the treatment goals once we start the therapy. So these are the ones we should really not leave unattended. We also see that, of course, also people without diabetes can have a cardiovascular disease, but the ones with diabetes are at even a higher risk, and that we need to see if we can do some benefits to both groups. So we know for the people with diabetes that we have benefits in cardiovascular protection when adding SGLT2s and GLP-1 receptor agonists, but we also need to see how we can even lower the risk in a broader population. When we look into the association of diabetes and cardiovascular disease and chronic kidney disease, cardiovascular disease to the left, chronic kidney disease to the right, we see that both diseases are substantially driven by diabetes control. So the higher the HbA1c levels, the higher the risk to develop both cardiovascular disease and chronic kidney disease. And there is a consensus out already from 2022 by the EASD, the European Association, and the American Association of Diabetes, where we have our treatment goals in a cycle where we really should use various approaches, where we need to implement a care plan, provide ongoing support, review the success, address the individual patient characteristics to overcome the inertia that maybe some people have, to consider adequate treatment, and to also follow up on that treatment plan. And when we look into the treatment goals, and that's already from 2022, so we have to the left people who have a higher risk in cardiovascular disease, and to the right, the people who have more of an obesity and overweight problem. And there we have a clear guideline that we should always use the best possible medication, which would be for the ones at cardiovascular and chronic kidney disease risk, the ones that avoid these risks, namely SGLT2 inhibitors and GLP-1 receptor agonists. And still, when we look into our clinics, we see a high number of people running around with inadequate treatment, being sulfonylureas or even insulin, when other options have not been used adequately. So we looked into our small country national data in a very broad cross-sectional study across various practices in primary care, and wanted to see what are the clinical characteristics of our people with diabetes and what comorbidities do they have. And what we see that still a high number of people is not yet treated with the more potent medications such as GLP-1 receptor agonists. And probably that can be because they are to be injected, and also the prescription process is more complex as compared to, for example, DPP-4 inhibitors that can be prescribed quite easily. When we then look into the people who have other medications on, so I think we are quite good in establishing blood pressure medication and lipid lowering medication, even if the uptake of some medication that could have additional benefit is not as high as we would have hoped. When we then look in that population, how many of the people have achieved their treatment goals, that is quite sad. So we do see that HbA1c goals are met in roughly 53%, blood pressure short below 60%, cholesterol below 50%, and altogether slightly over 10%. So that's really a room to improve diabetes and the more broader risk factor management. I came across during earlier today, an article about the global effect of cardiovascular risk factors on lifetime estimates. And that's a very interesting article published in the New England Journal of Medicine, where we can see that the avoidance of the classical risk factors, so meaning having no diabetes, having a normal BMI, a good controlled blood pressure, good controlled lipids, and being a non-smoker at the age of 50 years gives you a 10 years plus greater life expectancy compared to those who have those risk factors. So with that, I want to conclude saying that really we need a holistic approach, reassess the medications, reassess achievement of the goals on a consecutive way, and really strive for not only diabetes control, but also other risk factor management to really avoid cardiometabolic renal disease. Thank you very much.